Hi, everyone. Welcome to another Wednesday VMR. Thank you so much for joining us. I'm Charmaine. I am beyond excited today because I have the distinct honor of discussing a case with the one and only Yaz. How's it going?
Hello, hello. No, the honor is all mine. I'm really nervous, but I'm very happy to be here. Another Maddie case. Her cases have been like amazing. So let's see how we do today.
Look what I have. I have my coffee ready for me for a mighty case. A big shout out to Khashayar and Amalprit for scribing and doing teaching points today. And the wonderful Maddie. Thank you so much for presenting a case.
Of course. I love presenting cases on Wednesday in the Sharmin plus CP Solvers member of VMRs. And yeah, congrats to Yaz, just a shout out to the rest of the world on congratulating her on passing step 2. I hope you're okay with the whole world knowing that, Yaz.
Thank
But
you
I
so
felt like I
much.
needed to congratulate you.
I will always be grateful for all CPS team and all the IMGs and medical students I met in this journey. So I will do my best to help all of the next IMGs and applicants. So thank you.
Amazing.
Amazing. All right. So if you can get the board up, then we can get started, Maddie.
All right, perfect. Well, I'll give you all the first aliquot. And the first aliquot is a 78-year-old female who presented to the emergency department for
Oh, I'm so
generalized.
sorry,
Oh, go
Maddie.
ahead.
I think Khashayar might not be still co-host. Or Amalpreet, would you mind just sharing the screen if you can? All right, wonderful. Sorry, Maddie. Do you want
Oh,
to start over?
yeah, no problem. Oh, I just lost my case. Let's see. All right, so 78-year-old woman presented to the ED for burning with urination for 3 days alongside generalized malaise and some nausea. And she was brought to the ED by her daughter. And I'll pause there.
Okay, so I'll tackle this first aliquot. And first of all, it's an elderly woman. And thinking about dysuria, burning with urination for 3 days, the first thing we can think about is UTIs. We common things being common, right? Now, in women, we all know that because of the urethra is shorter, it's easier to have UTIs. So this, I'm reflexively thinking of not only looking for this infection processes, but also like a little bit more on the past medical history. If this is a elderly patient that has any special needs, if she uses diaper, if she has any urination incontinence, or if there had been other past medical history of other infections. And that would be like the first thing I would look at in primary care. Since I'm seeing some malaise and nausea, again, I will look for fever or chills to see if this hasn't progressed to pyelonephritis, because that's the first thing. In elderly people, it's very easy to have a very fast progression without a lot of without a very fluid presentation. So that would be the first thing I would do. What do you think, Dr. Sharma?
Oh, perfect. That was awesome. I 100% agree with you. Yes. So, yeah, I think like it's whenever the phrase burning with urination comes up, oftentimes we just like translate that as dysuria. I really love that you didn't stop there and you're like, yes, I want to make sure this patient doesn't have UTI, but what else could be? So, starting with like the skin, 78 postmenopausal, the other thing I would think about like the vaginal dryness, those things oftentimes can cause burning with urination as well. That is like hard to localize. And I love how you like thought about the systemic symptoms as well, because oftentimes like in a healthy young individual coming in, urinary like UTI symptoms like dysuria often is not accompanied by like malaise or like nausea or like generalized weakness. But again, with the older folks, they have poor reserve, so they can definitely have like cystitis with sepsis, or like pyelo with sepsis, as you mentioned. So oftentimes, like a smaller trigger can cause more significant effect on their present, on how they present. And also like being open to kind of like dysuria being a red herring. And, are we like with the nausea, are we dealing more like an abdominal pain issue? And I think like more history and more exam will help clarify that. So just not anchoring to the dysuria early. The one other thing that I love that you mentioned, Pilo, whenever when it comes like to a UTI, is UTI like urinary tract infection is pretty non-specific term. So from the get-go, I try to kind of thinking about the genital urinary tract and where, if there's an infection there, where it's coming from. I love that you mentioned like urethritis. Oftentimes with urethritis, we think about like STIs, and then thinking about like cystitis, pyelonephritis, and a man prostatitis as well. So like really, really thinking about where you think that infection is coming from, because it affects which bugs you worry about, and also the duration of treatment. For example, like acute versus chronic prostatitis versus cystitis versus pyelo, the duration of therapy differs. So that's something to also like keep in mind as we go through the case. All right, Maddie, back to you.
All right, I loved your discussion, loved how you broke down UTI into more kind of specific terms. All right, so for more of the HPI, brought in by her daughter, and the patient said for the past 3 days, she's had some nausea, not wanting to eat, some burning sensation with peeing, and also some dizziness with a mild headache. So the review of systems was mainly positive for nausea, dizziness, poor PO intake. She did not have any vomiting, diarrhea, no fevers or chills, and no abdominal pain. Also no hematuria, cough, shortness of breath, and she did not have any vaginal discharge or report any vaginal dryness. For her past medical history, she has a history of type 2 diabetes with the last A1C 6.6. She's had a history of previous UTIs, notably a history of ESBL UTIs in the past few months. She has a history of dementia, a history of hypertension, and she has a history of a recently diagnosed extranodal marginal zone lymphoma. And to give you just kind of a brief information about the lymphoma, so she was diagnosed 1 month ago in the setting of having some weight loss and fatigue and multiple soft tissue lesions that were identified on CT scan that were up to 10 centimeters, involving several regions like the chest wall, the axilla, the breast, the thyroid. And she had recently undergone a lymph node biopsy, which had resulted as marginal zone lymphoma. She had not yet started treatment, and her oncologists were actually concerned about a progression to a more aggressive lymphoma. So actually, the morning prior to her coming to the emergency department, they had undergone a repeat biopsy of a mass in kind of the left back. So she had just undergone a repeat biopsy the morning prior to coming to the ED. In terms of medications, she's on lisinopril, empagliflozin, metformin, and duaglutide. Social history, she lives at home by herself in Colorado. She has 5 children who live locally and visit her daily, and kind of the children take turns spending the night with her, so she never stays in the home alone. No recent travel. Health-related behaviors, nothing notable. She does not use tobacco, does not drink alcohol, and nothing notable on health-related behaviors. No allergies and no pertinent family history. And then for the vitals in the physical exam, in the ED, her temperature was 36.7. Her heart rate was around 75. Her blood pressure was 135/57. In the ED, she had 1 episode of a blood pressure of 91/60 and was then given fluids, and then went back to 135/57 roughly. And she was satting well on room air. In general, she was not in any acute distress. The main findings on the physical exam, she had some suprapubic abdominal tenderness. And then she had some tenderness in the area of the left flank, but that was also right where she had received the biopsy that morning. And I will pause there.
Should I tackle the aliquot first? Okay. So, well, now with all of this past medical history, we know that she has diabetes mellitus type 2, which predisposes her to UTIs. She's also postmenopausal woman. She has a lot of these different risk factors to present chronic UTIs that, I mean, by itself, a cystitis wouldn't cause nausea and malaise, although I would definitely, my reflex would be like UA and a cytology and to see what is going on. Now we know that this patient has lymphoma, and lymphoma, if I'm not wrong, there it can cause neoplasia, like neoplasia, other neoplasia like NETs, and one of them is bladder and renal cancer. Although this woman is not telling us that she has seen any changes on the urination, like hematuria, because I think the reflexively, all of us think like, oh, painless hematuria is renal cancer until proven otherwise. Still, I would definitely like to know if in the UA we find anything about that after you tell us that she just got her biopsy. But again, the first thing I would look at is infection. Again, common things being common, as Dr. Jazz likes saying. And in elderly people, try to be very aware that this can progress to urosepsis. And as the chat has mentioned, this patient also has empagliflozin therapy that increases the risk again of UTI. So she has a lot of risks in my opinion. What do you think, Dr. Sharmin?
Yeah, beautiful discussion. I totally agree with you, Yaz. And I think, thinking that taking the exam, the HPI, there's definitely with the suprapubic tenderness, with this prior history of recurrent UTIs, the fact that she's on an SGLT2 inhibitors, they're all kind of painting a picture of like, at least like a cystitis, and like getting your UA, urine culture, your labs is going to be very informative. I think the question is like whether we're just dealing with a urinary tract infection alone, with possible like some systemic involvement, whether it's like bacteremia, or is there like another thing contributing to her more malaise and nausea. One thing that I would say, like I oftentimes find that, oftentimes when people are getting a UTI or an infection, and especially as Maddie mentioned in the setting of like a poor PO intake, oftentimes people are like dehydrated, and oftentimes like just giving them some fluids and reassessing after that, like the number of times I've seen like giving fluids and people like feel so much better than before kind of helps gauge like how much of this is just like, the poor PO intake dehydration, and how much of it is like a UTI plus another thing. Just kind of thinking about, taking a step back. This is like an elderly woman who has now a new diagnosis of a lymphoma. So thinking about like, oh, she's probably more at risk of like metastatic infections too, with like being having a degree of immunocompromise. And I'm always like, whenever people have a procedure and are presenting after, the question that I ask myself is like whether this presentation at all can be related to the procedure that they had. And it sounds like she had a biopsy of the left-sided mass. I was like around the area where we look for CV tenderness, if I got that correctly. So but doesn't sound like there is like an overlying erythema. So thinking about skin and soft tissue infection, was there a tract created? So that is like another thing, and thinking about like, after getting labs, whether like imaging would be helpful to assess to make sure we're not dealing with any complications of the post-procedure. The one thing that, as you mentioned, like, the nausea, the generalized malaise, can you see that with a urinary source of infection for an older woman? Sure, but I think it's definitely worthy of pause and thinking about what else could be going on. And, but anyone with diabetes who has an SGLT2 on, I have trained my brain to think about euglycemic DKA. So that is another thing to like keep in mind as we like look through the lab to make sure we're not dealing with a side effect of a medication, especially when people have poor PO intakes. SGLT2s always make me a little nervous when people are in PO, not eating as much. So that's like another thing to keep in mind as well. Maddie, I really love the fact that you painted such a great picture of the social history of like, it's so important to know where our patients are coming from, and the fact that, she has family around that is like advocating and taking good care of her is like really important. The one thing that I always like want to make sure, it doesn't sound like she's altered, but like making sure she hasn't had any falls or anything else that we need to worry about when they come in. Um, so I totally agree with you. I think thinking about urinary source of infection, thinking about whether we're dealing with the complications of the biopsy or the malignancy itself, and with that nausea or malaise, are we dealing with like potential effect of her malignancy, or is it just her like acting more seriously, or something medication side effect, or kind of like how I'm thinking. Any other points, Yas, or any other thoughts?
I think I have nothing to add. This is amazing approach. And again, I amplifying what you mentioned. I really like the way that Maddie is like getting all this past medical history, all the social history. It shows how much she cares for her patients.
Yeah, absolutely.
All right, loving your discussion here. So to give you some basic labs, so a CBC showed a white count of 5, hemoglobin of 13, platelet of 172,000. The basic metabolic panel was all normal. So just to call out some specific things, she had a creatinine that was at her baseline of 1.14, a glucose of 137, but the basic metabolic panel was normal. They got a CMP, so the liver enzymes were also normal. T-bili, alk-Phos, AST, ALT, albumin of 4.5. A lactate was 1.2. A repeat A1C was 6.4. And a urinalysis showed pyuria with 50 to 100 white blood cells, positive nitrites, 1+ leukocytes. Specific gravity was 1.020, a pH of 5.5. There was negative protein, 4+ glucose, negative ketones, no blood, rare squamous epithelial, and many bacteria. And I'll pause there.
So we do have pyuria and we have what is it? Nitrates. So the thing is, I'm thinking the first bugs we can like imagine that is going on here would be E. coli. In elderly people, Klebsiella pneumoniae. In other, I'm wondering again. I think that after listening to Dr. Sharmin, knowing that this patient had a lymph node biopsy, if there are other bacteria like Staph aureus that could have entered through like the lymph node area, like the lymph node biopsy area. So I'm thinking this patient, I would put them on antibiotic therapy by the findings of the UA. Still, I would definitely do some cultures and then tailor the antibiotic treatment accordingly. Because one of the things that I've noticed is that urosepsis in elderly people can get ugly really fast. So that is my reflex. And honestly, I was expecting to see the CBC a little bit more um, like fluid and higher white blood cell count or a lower hemoglobin. So far, this is in my I think this is abnormally normal. So but I don't know what you think, Dr. Sharmi.
Yeah, no, I think you're absolutely right. Like, we know, like, with looking at the CUA, looking at that exam and that history. So, what does it take for us to diagnose as UTI? Is like symptomatology. Like, she's complaining of dysuria, she has suprapubic tenderness, and she has a UA that is compatible with a urinary source of infection. So I think you're absolutely right. Like getting the urine culture, in older people with systemic signs, I have low threshold of like getting blood cultures as well, and then starting antibiotics. She, as you mentioned, like I think I would go with IV antibiotics. The two things I like to do whenever I see a UA, I kind of like to trend my UAs the way like I like to trend my tropes sometimes. By that means I just like look at the old UAs and see like what this patient's UA has been like in the past. Some people have like, that often like helps me in setting up not this patient who already has, we already suspect a true infection, but people who come in with like, you know, a little bit of altered, they have a UA that is like a little questionable. So I like to like look at the old UAs and see like what has it been like in the past. Um, and then in terms of like therapies for him, the other thing that is like always helpful is like to look back and see has recurrent UTI. So think about like what bugs that they grew. And I think Maddie mentioned that she had an ESBL in the past, and that kind of informs your empiric therapies of like what antibiotics you choose. So you want to make sure like you cover ESBL in this patient until you get further information and further and then you can narrow it down after that. So I think now that we're in the land of like recurrent UTIs, is like worth pausing and thinking about like, okay, so this is a lady who's coming in with like recurrent UTIs. One thing to consider off the bat is like, you know, if SGLT2 is a good medication on him, oftentimes like when we think about recurrent UTIs, we really, I think like that's like a contraindications to SGLT2. So that's a medication that I potentially think about taking off for her. Then the other things that I think about in terms of a recurrent UTI is that, you know, we thought about like atopic vaginitis. So that oftentimes can lead to recurrent UTIs in a woman. In a man, oftentimes, you know, BPH, that's not the case we're dealing with, or chronic prostatitis, but again, not her. You know, she doesn't have the chronic Foley's. And the other thing to think about that is like more rare, like neurogenic bladder, like sometimes people have diverticuli within the bladder or fistulas that can lead to recurrent UTIs. And then, you know, with the ureter and the kidneys itself, like any cysts, stones that can be a nidus of an infection. So I think it's worth in this patient also to think about these etiologies. So thinking about like, again, getting like imaging, whether it's like ultrasound of the kidneys, like bladder and the kidney to start with, or, you know, she has a okay creatinine. We're kind of like worried about her nausea and the procedure, or like get a CT abdomen pelvis to take a further look to make sure we're not dealing with any complications of it. So, you know, now that we have a plausible potential etiology that is a urinary source of infection, you know, thinking about whether this is like cystitis or pyelo, I think how we're gonna label it is gonna be important. And also, we have like kind of two options now. Like one, give her antibiotic, give her fluid, and see if, you know, her nausea gets better, see if their other symptoms improve. If we give her some therapy and those symptoms doesn't improve, then we have to kind of go back to the drawing board and think about, are there anything else, especially like in the context of her malignancy, recent procedure that we need to investigate more. I think that's watchful waiting and using your time as a diagnostic tool. It's totally okay thing to do as long as she's hemodynamically stable. But as long as if she's like getting sicker and your therapies are not responding, then you might have to pull the trigger a little faster. Any other thoughts, Yas?
Yeah, definitely, this is an amazing approach. I am just wondering if in this case, anorexia, malaise, and nausea could be a red herring, or in a patient with a long-standing diabetes mellitus type 2, she could present gastroparesis, and that could be like something additional. And in this case, I'm wondering like if in primary care, if this is possible, like to have a gynecological exploration, because I mean, it's not only cystitis, it's like this has been chronic issues to see if there's, I don't know, any clue of her having like sclerosis or like planus or a fistula, as in the chat have very smartly like mentioned. All of those things that could be causing an issue like UTIs and chronic issues. So that's the only thing I would add so far. I'm wondering what else Maddie has for us.
Amazing. Yes, I totally agree. Go ahead, Maddie.
All right. So this patient, after the findings of the UA, she was started on ceftriaxone. She was given some fluids. A urine culture was sent, and eventually the urine culture came back with growing E. coli, with greater than 100,000 colonies per milliliter. At this point, the susceptibilities were still pending. And as I mentioned a little bit in the past medical history, so she's had prior UTIs, and we looked back, and several of them were ESBL. When talking with the family, that they think that these were more frequent since starting the empagliflozin. She specifically had had 3 UTIs in the past 2 months and had started empagliflozin several months prior to that. And I'll pause there.
Well, in this case, I think that if anybody can correct me, the IDSA also mentions that ceftriaxone is a good choice to prefer antibiotics for any UTI caused by E. coli that does not inactivate lactamases. So E. coli and trimethoprim sulfamethoxazole would be okay. So after this, as Dr. Sharmin mentioned, I would put it watchful waiting to see if she answers to this, she responds to the treatment. Again, trying to avoid this progression to sepsis. If not, I think that I would try to add a level fluoroquinolone, like ciprofloxacin. No, I would add definitely fluoroquinolone, or try to like tailor this patient, get fluid, get treatment, and again look for the chronic causes and try to, as Dr. Jazz mentioned, like maybe vaginal estrogen. Because one thing that I've noticed, and I think that we all had a family or a patient on our practice that comes regularly, and this can cause a lot of like issues on like lifestyle, on like quality of life. So that would be my approach, like watchful waiting, tailor treatment, maybe add or change antibiotics, and look for the root cause.
Yeah, beautifully said, Yas. Yeah, I think it's time to discontinue the SGLT2 for now. And yeah, anything like ceftriaxone, like in all comers with UTI, is a great choice. I mean, ceftriaxone is a great antibiotic. In fact, it's my favorite antibiotics. It's like actually broad; it covers so many things. So I love a good ceftriaxone. That being said, I think like it depends on where this patient if this patient is like getting admitted, I think like giving ceftriaxone and seeing what cultures grow and how she does clinically is a fair approach. If this patient is like it looks okay and is gonna go home, with history of like ESBL, as long as like there is a way to contact the patient and give her a change of antibiotics, then I just worry about someone who's grown ESBL in the past. Again, I've definitely seen prior ESBL and then growing a pattern of that is not resistant. So that is definitely a possibility. I think as long as you have a good follow-up plan for the antibiotic you choose, it should be okay. So if you're getting admitted, like if she's clinically not doing better, then brought in, or when the cultures come back, then brought in. The issue that always like happens sometimes is like when you start an antibiotic, people clinically improve, and then the cultures come back resistant to your antibiotic that you had chosen that they clinically improved, which begs the question, was there another bug, or is not actually a urinary source of infection that you're dealing with? So I love medicine. It can get so complicated sometimes, even a single UTI. And I love this is a UTI case, Maddie. I love it so much. So I think like, this is someone that, given her past medical history and like the fact that she still has some of the symptoms that we haven't really explained and worth watching, I would favor like admitting this patient to medicine, at least for some observation, and see how she does until like the susceptibility to come back, until to make sure, as you mentioned, the PO intake, we can like see if there's anything we can help with that as well. All right, Maddie, back to you.
All right. So exactly as you said, so she was started on ceftriaxone with the plan to kind of wait for the susceptibilities and then brought in depending on how they come back. Eventually, the susceptibilities came back pan-sensitive, even though she had had a history of ESBL, so she just continued on the ceftriaxone. And so just to kind of share kind of what happened with this patient. So, usually basically the final diagnosis here was a urinary tract infection, specifically kind of an uncomplicated cystitis. So she was admitted, and most people with uncomplicated cystitis don't get admitted, but I think the thinking that the team had was there was initially a concern for potential pyelonephritis given that one episode of hypotension in the ED that ultimately, never recurred. And I think another reason why she ended up being admitted for kind of watching is she had this, history of lymphoma that had not yet been started treatment, and her oncology team was concerned of potential progression. And with a headache that she was reporting, the ED had actually gotten some head imaging to make sure there weren't signs of metastasis, which there were not. But that was kind of part of the reasoning behind the team wanting to admit her. So yeah, basically, the final diagnosis in this case was a simple cystitis, urinary tract infection, and I think the repeat biopsy for the lymphoma did not show progression, which was wonderful. And, I learned from this case that, E. coli accounts for a huge percentage, 75 to 95% of cases of uncomplicated cystitis. And then the rest of the bugs are things like Klebsiella or Staph saprophyticus or some Enterococcus, but really E. coli is the main bug. And then I really loved both Sharmin and Yaz's discussion of kind of when thinking about recurrent UTIs, and most commonly it's due to some kind of anatomy of the urinary tract that increases the risk. So whether it's a Foley or atrophic vaginitis or a stone or in a man kind of BPH. And in this patient, they're given kind of the history that she had more frequent urinary tract infections with empagliflozin that was discontinued. I tried to look into, because I feel like I had heard just that, SGLT2 inhibitors can increase the risk. And I found some conflicting data, some papers that said, it slightly increases the risk, others, and I think Austin said in the chat that it mainly increases the risk for fungal infections. So I still need to kind of dig a little bit more into that, but regardless, this patient was stopped. Empagliflozin was stopped for her, given that it seemed like with the initiation of that medication, she had more. So yeah, that's how this case unfolded.
This is amazing, Maggie. Thank you for bringing this types of bread and butter cases. I think this is very important to have in our repertoire, knowing that going on to treatment of elderly patients with chronic UTIs, it's a very annoying thing for them. So I think that next steps would be like trying to give them like tips of how to prevent UTIs. There have been like estrogen therapy, as has been Dr. Jazz, again, shout out to him in the chat, for women. Or there are other non-pharmacologic treatment like cranberry juice and stuff, and hibiscus that are not do not have like a lot of strength in articles, but there are some like things that we can advise our patients, obviously based on evidence. And yeah, definitely love it. Like E. coli is a very nasty bug. Nitrate positive, a little pearl here is that although they are known to be nitrate reducing bacteria, only like around 30% can produce it. And the reason for that is because that they use ammonia as their nitrogen source, which is very predominant in urine. So that's why they really they prevail in UTIs. So that's a tip on this bug.
I'm always impressed with your infectious diseases knowledge. Yes, I need to call you up every time I have a case. Maddie, I'm so happy. This is such an amazing case. And yes, more of this. Like, this is bread and butter medicine. These are the things we need to have a good understanding of, knowing how to tackle, because we see it so much. So thank you so much for presenting this. I remember being in like medical school and thinking like, UTI, AFib, easy. Now as an attending, I struggle with UTI. I struggle with AFib too, because like it's actually a lot more complicated, especially in older patients, thinking about wherein the genitourinary tract is coming from. If it's recurrent, what do you have to think about? A duration of therapy is a big one. I'm curious to hear, like, did you guys how many days did you end up treating her for an uncomplicated cystitis and someone who has like recurrent and maybe some systemic signs? But yeah, and again, like, kudos to starting a subtraction and then watching the cultures, I think that's absolutely a great choice. I think with a lot of these things is like, what is your follow-up plan, right? Like, okay, we can any plan can almost be good as long as you have a really close follow-up plan for the patient and like able to pivot when things are not going in the right direction. So I think this is a fantastic case. And yeah, and I think in terms of the SGLT2 med, yeah, I agree. I think anecdotally, whenever there's recurrent UTIs, I always like thought about like whether it's kind of a double hit, like they have a propensity, maybe another reason for UTIs and the glucosuria and other aspects of that. It's potentiated by SGLT2 might not help. So I think like holding the SGLT2 and see how she does will be informative. If she has like another recurrent UTI, then having to go look for another etiology. I think that's how I would approach it. Yeah, how long did you treat her for, Maddie?
Yeah, so I wasn't even the primary. I actually saw this patient when I was on cross cover. So I wasn't even the primary team, but I just I know that we've been wanting to get more bread and butter on VMR. So when I saw a simple cystitis case, I'm like, gotta present this one. But I think the team she had, was really wonderful. I kind of mentioned the social history. She has a really amazing family support and is connected with care. She had a primary care appointment even the next week and an oncology appointment the week after. So I think the plan was to treat her for 5 days, 3 to 5 days for uncomplicated cystitis. And she had a PCP appointment the following week. And so I actually just looked back at her chart and I saw in the PCP note that they had stopped empagliflozin and her symptoms had resolved with that 5-day treatment.
Wonderful. Yeah, I think, I think in someone, if like a simple cystitis, like even uncomplicated cystitis that requires you to get admitted to the hospital, I think like 5 days is very fair. I think like outpatient or like if there is a UTI and other reasons, then I like tend to do 3 days. But yeah, I think in this person, I would also do 5 days. Sorry, our ID friends. Thank you all so much. This was such a fantastic case. Yaz, any other reflections, comments?
I'm good at
Great
it.
job.
Actually,
You're amazing.
just chef kiss. I love this, Maddie. I really like this. I really like bread and butter. And if it's ID, I am happier. But yeah, thank you so much.
Maddie, amazing case. Thank you for presenting a bread and butter case. This is awesome. We should do more of this. Yes, incredible job discussing. You are a queen. Thank you so much, Kashayar, for doing the scribing. And then Anil Preach, we are ready for you.
That's an amazing case. Thank you so much, Maddie. And what an amazing discussion to take out the key points out of cystitis case. I learned a lot. Thank you so much. And so if we talk about the teaching points, the patient came with burning micturition. Then we thought about common things being common. What do we need to rule out? We need to consider a UTI, a urinary tract infection in this patient. And in fact, it is more common in women because of the shorter urethra. Secondly, vaginal dryness in postmenopausal women can cause burning micturition as well. So these were some of the things we were considering. And then we were thinking that we had to evaluate some systemic signs which could indicate if there is a sort of infection going on. Then we thought that past medical history would be very important to check if there has been recurrent episodes of UTI. Then we need to evaluate what the cause of the recurrent episodes of UTI is, or is it just a single episode? And evaluating other past medical history in terms of immunosuppression would be important too. And then in elderly patients, we can also get the other lower urinary tract symptoms, which can occur in some kidney disorders. So we just thought that we need to take a proper history. A history would be the key to evaluate this patient. Then ultimately, we realized that this patient had recurrent UTI. So we started thinking about the risk factors which can lead a person to have the recurrence. Number one was immunosuppression that was present in this patient, secondary to lymphoma, diabetes mellitus. Secondly, this patient was on empagliflozin and dapagliflozin, which can increase the risk of UTIs and more specifically fungal infections. So these all the risk factors we were considering. And then we also discussed in the chat that in an elderly postmenopausal women, because of the vaginal dryness, a vaginal estrogen can also help in case of recurrent UTIs. Then we were talking about how to treat this patient. So we have to first evaluate if it's an uncomplicated UTI or is it a complicated UTI. And according to that, our treatment can vary. So we can also trend the whole urine analysis, and we can start with the antibiotic therapies, get the urine culture and tailor the antibiotic therapy according to that. It also reminded us of an NEGM case where a lady who presented with recurrent UTIs and vitamin deficiency was found to be the cause of all of that. So this evaluating recurrent UTIs is also a very broad topic. And then we also discussed what could be the other causes for that. BPH can cause UTI in males, and because of all the hesitancy and all the lower urinary tract symptoms. And then a fistula, which can open into the urinary tract from some other part, can also cause UTI. For example, a colovesical fistula from Crohn's disease, or maybe a lymphoma, which is affecting the colon. A fistula can cause that. And then we also discussed that any lesion can cause burning on urination. So groin cellulitis is also a differential. So after evaluating everything, we realized that it is a case of uncomplicated cystitis. And the treatment was done according to that. But the discussion was very, very rich because we understood what the various causes of UTI can be and what can cause the recurrence. So I learned a lot. Thank you so much.
Amazing teaching point as always. That was so fantastic. Thank you so much. I really, really appreciate you. Thanks again, Yaz. Brilliant discussion. And thank you all for joining us. Maddie, thanks again for presenting the case on cashier prescribing, and all of you for all the amazing pearl in the chats. Appreciate you all. See you tomorrow. Bye.